Did you feel that? Are you all right? Just a little pressure now.
Even with meticulous technique and precise dose selection, spinal anesthesia carries a persistent failure rate of just under 1%. When a block fails in the operating room, the immediate consequences are twofold: severe psychological trauma and physical pain for the patient, and serious medico-legal risk for the provider. Surviving this margin of error requires early detection. The anesthesia provider must actively monitor the patient's autonomic responses immediately following the subarachnoid injection. This chart illustrates the earliest indicator of a successful block. While heart rate remains steady, blood pressure suddenly drops. If 15 minutes pass post-injection and the blood pressure line remains completely flat, the block will be inadequate. The absence of this autonomic response at the 15-minute mark is a definitive signal. It demands immediate clinical intervention before the surgical incision is made. Once that 15-minute window closes without effect, providers must pivot away from standard protocols and execute a targeted differential diagnosis to identify the physical nature of the failure. This diagram maps the decision tree for managing failures across 5 distinct physical architectures. The first branch is Scenario 1, no block. This complete failure occurs when the injection hits an incorrect anatomical location, an incorrect solution is used, or the drug is defective. The strict protocol for a no-block scenario requires waiting a full 20 minutes to confirm absolute failure before even considering a repeat injection. Violating this wait time is hazardous. Combining a slowly developing first dose with a second injection risks triggering a dangerous total spinal block. This leads to a core rule of the protocol. Routinely repeating a subarachnoid injection for any type of partial block is highly restricted. Pharmacologically, delivering high intrathecal concentrations of local anesthetics can trigger severe neurotoxicity. There is a specifically documented risk of lesions forming on the cauda equina, resulting from multiple injections via an indwelling catheter. This animated view shows the anatomical risk. Injecting a second dose into a space with an existing physical barrier forces the anesthetic to pool rapidly and surge upward. This spread reaches the upper thoracic and cervical levels, causing profound cardiovascular instability and respiratory embarrassment. Attempting to bypass the problem by switching to an epidural is also likely to fail. The same anatomical obstruction blocking the intrathecal spread frequently distorts the surrounding epidural space. Repeating a block is extremely dangerous. Resolving a failure typically requires physical manipulation of the patient, rather than blindly doubling the pharmacological dose. This brings us to Scenario 2, a spinal block of insufficient height, where the anesthetic fails to reach the required dermatome level for the surgery. Physical causes include a lumbar puncture performed in too low an interspace, anesthetic leaking at the needle-syringe connection, or an anatomical barrier preventing diffusion. The primary countermeasure to this problem is utilizing gravity and postural manipulation to physically steer the injected drug. When a hyperbaric formulation is used, the specific protocol is to place the patient in the Trendelenburg position. This 3D model shows the musculoskeletal mechanics. The lower spine's inward curve acts as a physical hill blocking upward fluid movement. By flexing the patient's hips and knees, we flatten this anatomical hill, allowing the dense injectate to flow smoothly toward the target nerves. There is a strict clinical caveat here. This positional change relies entirely on the specific gravity of the drug, and it is highly unlikely to succeed if an isobaric formulation like plain bupivacaine was used. Scenario 3 is the unilateral block, characterized by anesthesia taking effect on only one side of the patient's body. This axial cross-section demonstrates one of the primary root causes. Aside from patient positioning errors, a thick central longitudinal ligament can act as a physical wall, completely blocking fluid from spreading into the opposite hemisphere. To intervene, the clinician must physically roll the patient so the unblocked side faces downward, utilizing gravity to encourage bilateral spread. If bilateral spread fails, the block may be deemed sufficient provided the surgical procedure is strictly limited to the ipsilateral, or currently anesthetized, lower limb. Mastering spinal anesthesia requires treating it as a fluid dynamics problem. Leveraging the specific gravity of the drug against the geometry of the spine allows providers to actively bypass anatomical barriers. The final two architectures of failure are Scenario 4, the patchy block, and Scenario 5, inadequate duration. A patchy block describes an inconsistent blockade presenting with highly variable sensory and motor effects, even when the anesthetic initially appeared to spread adequately. The mechanics behind a patchy block typically come down to the administration of an insufficient dose of the drug, or the solution failing to fully reach the target area. Inadequate duration can result from the surgical procedure outlasting the anticipated timeframe, or from a syringe swap error, where a short-acting agent like lidocaine is accidentally injected instead of the intended bupivacaine. The clinical intervention for both of these pharmacological shortfalls is strict. Because the intrathecal dose is spent and repeating the injection is unsafe, the provider must immediately supplement with intravenous analgesia and sedation. The recommended pharmacological tools for this transition involve utilizing low-concentration intravenous infusions of propofol and remifentanil. When the mechanical limits of the subarachnoid block have been definitively exhausted, the provider must abandon the spinal approach and secure the patient's comfort via systemic intravenous control or full conversion to general anesthesia. Managing a failed block does not end when the surgery concludes. It requires rigorous, mandatory follow-up outside the operating room. This documentation is the foundational requirement. The provider must give a full explanation of the events to the patient and thoroughly document the failure in the medical record to adapt future anesthetic plans. During follow-up, unusual failure patterns serve as critical red flags, potentially indicating serious underlying neurological pathology. For patients presenting with these red flags, or those with a history of repeated failures, the clinical next steps require a formal neurology consult or a spinal MRI to delineate abnormal anatomy. The final and rarest variable in the failure matrix is the possibility of a faulty batch of local anesthetic. Modern heat sterilization and rigorous quality control processes make defective amide anesthetics an exceedingly rare occurrence. However, if a technically simple procedure fails completely, or if multiple unexplained failures cluster within a single department, an investigation into the specific batch, most commonly hyperbaric bupivacaine, is warranted. By integrating immediate physiological detection, precise anatomical interventions, and rigorous postoperative investigations, clinicians can successfully neutralize the inherent risks hidden within that 1% failure margin.